Sauder, and I'm part of the Division of Surgical Oncology, and if you come near me, I'll talk to you a lot about breast cancer. But today I'm going to talk about surgical education as one of the assistant program directors too. So probably the mantra that has been within surgical education for a long period of time came from William Halsted. It's a see one, do one, teach one. I think everybody around here has heard that and probably knows that. And Halsted sort of started this back in 1890 when he became the chair at Hopkins and started the first residency. It was the first formal training that any U.S. physician had. The graduates were, prior to that, were either just went from medical straight into private practice, or they did an apprenticeship. Those were really the only ways to become a surgeon other than going abroad and getting some training. This was sort of interspersed with residency, which he started until the 1940s when boards really started requiring us to have some sort of specialized training. People at that time lived in the hospital. They usually would be on call every other day, and would be on for 36 hours and then get a night off. This is why a lot of times people are known as house officers, because really they lived there. They were unmarried, mostly men. And it really became a time to pursue problems in depth. This was the case in 1984 still, when somebody with an 18-year-old girl named Libby Zion actually came to NYU and died from an undiagnosed disease. It became very public because her dad was a prominent lawyer and journalist in New York at the time, and people really started to look at the medical system and how we educate and who is available. In 1999, the Institute of Medicine put out a report, To Err is Human, Building a Safer Health System. And in this, they actually quoted that as many as 98,000 people die a year due to medical errors. And people started truly looking, and there was a lot of societal pressure looking at how we educate people, especially in the academic institutions. And it was looking at quality of care that we were providing. And this led to what most people in this room know as work hour restrictions. And in 2003, the ACGME put in 80 hours a week, 30-hour shift length, 1 in 7 days off, and no more than every 3-day call. All the residents know this well and faculty know it as probably a significant change than when some of them trained. It has continued to evolve, and in 2011 they put a few more restrictions in that interns can't work more than 16 hours and no more than now a 28-hour shift length. There have been studies starting to look at this with the first trial within surgery and trying to actually put some science behind this, because these were just sort of non-evidence-based guidelines that were presented. So it's really truly led, because of all of the societal pressure and differences that have been seen, to a residency re-evaluation, a re-evaluation of how we teach and how we assess residents. It's no longer this time period where there's an attending physician and then the chief who are operating on a patient while a variety of people are standing around learning, because that is not what we have access to anymore. And so as a society, and surgical educators, what have we done? We started to look at actual learning theories. Probably one of the most well-known people at the time that some of these changes came around was somebody by the name of David Kolb and his experiential learning theory. We as surgeons are very experiential learners, a lot of us, and so not surprising that this has become part of how we evaluate residents and what we look at, that people really have a concrete experience. They do something. They reflect on it. They do conceptualization or concluding from that experience, and then they plan for their next experience. And we slowly do this better and better sort of as we go along. And we move from this land of novice, which is where a lot of our third year med students start, to advanced beginners, to competent, to proficient, and then ultimately, hopefully, to be an expert and a master as we go along. How do we assess this? How do we look at this? There's Miller's pyramid of learning and assessment, which is particularly relevant in medicine and where it was developed. Students start when they are in medical school, sort of down at the bottom, in this fact gathering, this learning, this sort of theory-based abilities that they have. They sit in class, they have multiple choice, true false questions, and slowly as they start to learn how or know how, they do case presentations and they continue to assess into this behavior portion where you get more and more sort of autonomy as you start to go up. You start to do OSCEs and learn simulation. And then really where we as faculty and residents and such are in this top portion, that this does, that we do things, that we have direct observation of people, that it's really work-based assessment, that we, as a group of educators of all residents, it was decided that there are 6 competencies that everybody expects residents to obtain a certain level in: patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. This doesn't matter if you're a resident in radiology or a resident in surgery, the same overall competencies are expected. But really there are sub-competencies within this that come down to 36. And in each of these areas, we expect people to move up this train from novice to beginner to competent to proficient. And it's like a baby learning to walk, that they sort of start on the back, and probably people have seen this, and then they learn to roll and learn to crawl, and in the end stand up, and then in the end walk. And in general, people move along specific milestones within this at different rates and in different ways. And that's really what milestones are, that they are sort of within a competency, looking at the journey, making it sort of a trajectory so that we know how people are progressing. And there's oftentimes more than one path, just like there's more than one route to get somewhere. It's not all of a competency. It's not actually an assessment of the learner, these milestones, and it's really not supposed to be promotion criteria. So most people, as they go through this, go on sort of a wiggly path, but generally along hitting all of the milestones. We know that for some people, that path is faster and more steep, and others it's a little slower and moving along. It really has to do with time. It has to do with sort of non-timed periods that people get to. And within each of these, there is really curriculum and assessment that we have to do in order to see where somebody is at each of these milestones. And based on this, these are very abstract and not practical to daily sort of life and assessment. And so there's a new concept that was introduced in 2005 in an effort to translate these theoretical ideas of education into practice, allowing faculty to make competency-based decisions about the level of supervision. And really, in definition, those are called Entrustable Professional Activities, or EPAs, that you'll hear about. They're a unit of professional practice that can be fully entrusted to a trainee as soon as he or she has demonstrated the necessary competence to execute this activity unsupervised. When you deconstruct this, we really look at each of the words, and they each mean something important. It's entrustable, an act requiring trust. This includes knowledge of one's limits, meaning discernment, communication honestly and truthfulness, and filling one's commitments, being conscientious. it's professional. It's confined to occupations that have extraordinary qualifications. And I think any of us could say that surgery falls into that very easily, as well as medicine overall, and that it's activities or tasks that are done daily in our normal life. It's supposed to provide a context within which you can demonstrate the competencies that we know to be important for graduation, for proficiency, for practicing of the craft. As you see sort of in this little table, that competencies are bits and pieces within sort of professional activities. Not every competency is seen in every EPA, but there are bits and pieces of it. And it integrates them together. So if you look at it graphically, it looks like this, that an EPA really takes bits and pieces of competencies and even sub-competencies, and then milestones at which point people are. So maybe in one competency that you are a novice, but in another one you are proficient. And it really, each one is taken as its bits and pieces. EPAs are really units of work, whereas competencies are skills, values, attitudes. They're characteristics of the person, and milestones are your location on a trajectory within it. So entrustment, probably the most important word out of EPAs. It's something that as surgeons we are well known at. We do it daily in the OR. Though EPAs are just a new formalization of this, we seriously on an ad hoc basis do this multiple times during every case. In the context of the operation, you have to look at variables about a learner, whether they are tired, are they confident, their level of training, attributes of us as supervisors, are we lenient, are we strict, the context of the day. Is it early in the morning? Is it late in the day? Do we need to move things along? Is the case really complex? Is it something that we normally look at and normally do? And how do we evaluate that? So somebody named Zwisch, who was the chair at Kentucky, came up with a sort of 5 levels or 4 levels of supervision. That there's show and tell, where we as educators really show somebody and tell them, and the learner is able to observe, but there's no really execution by them. There's active help, where the learner does most of this, but we intercede constantly with them. There's a passive help, which is more of a reactive supervision, that we allow them to lead and we sort of intercede as needed. And then finally, supervision only. And supervision only really is where we try to step back. And you'll see as people progress, the amount of supervision only increases and the amount of show and tell decreases. But it really does matter on the case, and it's an interaction between 2 people, the learner as well as the educator. And once you actually qualify and sort of have grown through this, you get to provide supervision to the trainee as a colleague more. So how do EPAs sort of look? It looks sort of like this when you put it all together. That on each EPA, people progress and they gain confidence and they become competent at different points. And as we continue on our lives into deliberate practice, we actually continue to grow and try to become into a master and an expert. And if we don't continue to maintain those skills, that we will also drop off. So this has actually started as all this theory that you've heard gaining traction in the US, especially at the medical school level. In 2014, the AAMC published guidelines of 13 tasks that all medical students are supposed to be able to do by the time they enter residency. no matter their specialty, without supervision. And really this is based on guidelines that people say that medical students aren't ready and that there's not a curriculum overall. And if all the new interns look at this list, it's stuff that you do every day, right? That you walk in day one, and as somebody asked during our boot camp, who is going to sign off on their orders? The answer is nobody. And that you are supposed to be able to do. And so it's doing a history and physical, differential diagnosis, being able to interpret diagnostic and screening tests, write orders, write prescriptions, document in the chart, give an oral presentation, basically do evidence-based medicine, be able to do a handover or collaborate with other people, be able to tell if somebody's sick or not sick, be able to do an informed consent, generalized procedures such as putting in a Foley or an NG tube, and really be able to know what a safe situation is and how to help a culture of safety when you don't know. Currently, it's being piloted as a formal evaluation at 10 sites. They're 2 years into a 5-year pilot, and what they've learned so far is that in order for this to work, that you have to employ a systematic longitudinal approach. It's not something you can do. It's not something that one person can do, that it's a overall more portfolio looking. You have to ensure formative feedback so people know what they need to improve and how they can improve it, and create a process to render and maintain formal entrustment decisions. So once you gain entrustment within one group of people, that you shouldn't have to go and prove yourself somewhere else, because you do this with national norms. We're also looking at it in surgery. Starting yesterday, there is a 2-year pilot that actually has EPAs at 28 sites. It's a mix of community and academic practice, that it's a collaborative effort through a lot of groups that are education-based and care a whole lot about resident education. And they've looked at them and they are assessing, is it reliable? Is it cost-effective? What is the path to entrustment? Because that is what I would say that most residents say, is that they want to be entrusted and they want to be proficient by the time that they're able to graduate. Who makes that decision? When's the decision made? Do they tell the residents? How do they actually give formative feedback in order to be able to improve that? And how do we train people to be able to do this? Because as I said, it's really in daily practice that this is done. And so all of us as faculty members of residency really are the people that perform these and evaluate these on a daily basis. They've chosen 5 places to start this with, being able to evaluate and manage a patient with an inguinal hernia, evaluate a patient with right lower quadrant pain, and manage appendicitis, evaluate and manage patients with gallbladder disease, be able to do a general surgery consultation, and evaluate and manage a patient with blunt or penetrating trauma. Things that we do every single day as general surgery residents, and are by far not encompassing all of what we do, but a good portion of what you're supposed to know. What does an EPA for surgery look like? It looks, for trauma penetrating, this is just a small portion of what one would look like, that there's patient care and communication skills that both go into as competencies, taking care of a gunshot wound to the chest, that you have to be able to do efficiently an H&P, do procedures, whether that be a thoracotomy or a chest tube, that you have to have communication skills, you have to be able to talk to consults, you have to be able to talk to the family, and that those are actually different skills, and that you can be at different levels on this in each one. So, in summary, with recent concerns over the preparedness of graduates for general surgery training, in an unsupervised manner, we have to have the time of introducing competency-based assessments, and it's based on theory rooted in daily practice. That it's not time, but milestone guided, and that it encouraged graduate graduated entrustment so residents can gain confidence prior to graduation. As a great educator that taught me said, that when you do it all yourself, you make patients better really truly only one at a time. But when you teach residents, the effects on each patient you care for are tenfold. So, I want to thank a variety of people, those that educated me, those that have done all this magnificent work, and I have borrowed shamelessly as I have gone through. The clerkship and program directors here at UC Davis who really look at this and think about it every single day, as well as the residents and medical students who work with us on a daily basis and go through this. And last but not least, my home team. So. Questions?
The future of surgery and entrustable professional activities.
Yes. They're not going away.
They're not going away. The 28 programs that are trying it out that started in July, do you know any of them?
I know I can name some. I cannot name all 28. So I know OHSU, UAB, Northwestern, they all are part. Do you guys know any of the other ones? I know that there are some community practices.
Each of those programs you mentioned, their chair has been on the American Board of Surgery for the last decade or so, and have always been interested in this, is pushing this concept forward. And each of them has been sort of pushing for some reason to try to change surgical education from a time-based, which is really what it amounts to competency-based and individual skills. So, questions? I saw a few hands up there. Yeah, Laura.
I'm just wondering about the degree of autonomy that's sort of expected in the term manage, you know, the appendicitis or acute cholecystitis or those type of disease processes. What does that look like in terms of the operating room and the vision of this entrustable professional activity paradigm, and how would billing work in that scenario?
That is a great question. That is not answered, hence the pilot. But I think that the goal is that you would reach a level of competency, which is still a lot of times having supervision, or with that sort of passive supervision that, you know, maybe somebody's there with you, but you're guiding the procedure, I think would be the overall plan.
Sure.
So does this mean at first new residents will be able to do less until they're entrusted with activities, and you'll have sort of entrusted gates where someone will ask you, are you entrusted to do this? Or is it more when you move on, you have a list of all these things that you know, got confidence on?
So as of right now, you basically have to prove your entrustment to everybody, right? And I think that the long-term overall goal, and I think it's a long time coming, is where there is this entrustment that we know in order for you to graduate that you have met some of these standards and are able to do some of these things, hence the national norms. Yes, Alicia.
Hi, kind of piggybacking on that, one of the great things about this program is working with dozens of attendings, and one of the frustrating things is working with dozens of attendings. So where is the aggregate review that signs off on, you know, they've met this milestone?
So
It's right there.
So are you talking about here or in theory?
I guess in theory, because I know we're not the only program that is this large. We're not apprentice-based anymore, it's service-based.
So I would tell you that programs that are really going, because there are some programs that are going to completely EPA-based, so Northwestern is one that's doing a completely overhaul of their entire especially medical school curriculum, that they actually, for people to graduate, sit down as a committee, and there's a portfolio of all of these evaluations that people have done, like how'd you do as on H&Ps within medicine, how'd you do on surgery, and they actually sit down as a group and evaluate somebody in order to graduate them. It's really a portfolio base. So, other questions? Yes?
So I've heard a couple of talks about this
Yeah.
EPA paradigm shift, and I think it's really a great way that residents will hopefully get more autonomy. But these are the first actual, this is an EPA that I've seen presented, and they seem a lot broader than I expected. When you're talking about an EPA of managing a trauma patient, that can mean things that I'm totally comfortable doing right now. And it can mean things that I know I won't be comfortable doing maybe ever, and certainly not by the time I graduate as a chief resident. And so how are they going to make it specific, or at least more specific, even in appendix or gallbladder? You can look at a gallbladder and be like, okay, this is a gallbladder I can do. Or you could look at a gallbladder and be like, oh my God, and get ready to open and call Dr. Anderson.
Well, I think that
He's already in the operating room.
I think that's the thing, is that we realize that within an EPA that there are different competencies, and it really matters within that how challenging it is. Is it a typical gallbladder? Is it a complex gallbladder? Is it somebody who now has cancer? And sort of within that, knowing where you are at each of those stages, and that you are no longer a novice, maybe at a straightforward gallbladder, that you are proficient. And that's where sort of the overall portfolio comes together, looking at you as a whole person, sort of to hit certain milestones as you go up. And as I said, milestones really are just showing where your trajectory is. It's not that necessarily everybody walks on each step all the way up. Yes. Travis.
I guess, have there been, I'm curious maybe what your thoughts are as to some of the biggest barriers. When I hear more autonomy, of course, certainly that means less control for me. And so what are the barriers? There's a lot of talk in terms of, from blogs and reading through the ACS on being a mentor, what a good mentor is, and how do we, provide, good foundation or good platform for education. And, then you, of course, have society's expectations. And, I guess, how does that all, what are the barriers? How do we meld expectations and desire to learn and the need to learn to, the control freak nature of the surgeon, especially the procedures, right? And then society's expectations that have zero, and have the best. Everybody wants the best.
So I think that's where the formalization of entrustment and really making it a standardized process allows people to understand and become more apparent of what it is that's done. I think that as it grows and we realize that people really truly have mastered some of these things in a discussion, we are able to entrust once there are national norms that people have met, and it becomes less subjective and more objective. And I think that all of us work better with objective data, in medicine overall. And I think that maybe with that, we'll beat away some of these 200 years of sort of lack of trust that we give into our residents.
What's the latest interpretation or discussion of time-based training versus entrustable professional activities? So conceptually, you could graduate early, less than 5 years, if you do all your professional activities and they're all checked. Alternatively, if you don't accomplish them, you could never graduate. You could take 6 or 7 years to do it. Yet we're sort of stuck in a paradigm because of funding of a 5-year residency block. So where is that discussion about converting professional activities into changing the length of residency? Where does that sit with the discussion?
From my understanding, and maybe Skeeter knows better, or I think Joe left, but I don't think that they are necessarily one and the same. I think that they're sort of a little bit two different ideas. Like the concept of milestones really are these points that you sort of move along and they show a trajectory, whereas EPAs really are overall looking at your daily life and are you entrustable within that, not necessarily points of graduation or moving on. And as you would see, that really the amount of supervision is variable by person, by situation, by time of day, and all of that gets taken into a consideration.
Steve, you want to add anything?
You want to add anything?
No, the majority of the work being done in professional activities is at the UME MD level with medical schools, some of the, like I've seen the programs out at OHSU, which are, they're actually kind of impressive, where, you know, they've got these committees set up, and it's kind of set up like video games, like for the medical students earn these achievement badges, and they have this portfolio of all the things that they've been able to do, which you can imagine is just a lot more complex when you try to apply that to graduate medical education or surgical education because of, you know, procedures, even the variability between community program versus an academic program, and trying to make all of that uniforms is like a gargantuan task, which is why that pilot study specifically didn't want 28 academic programs, right? They were looking for the spectrum of the different kinds of residencies. So I know that there's the big push to try to translate some of the EPAs that they're already having at least descriptive success with at the undergraduate level, but figuring out how to apply it at the graduate surgical level is challenging. I mean, even just thinking about doing the schedule now, you know, is very challenging. And then imagining that someone is sort of like a PGY 3.6 and someone else is a PGY like 1.5, and the 1.5 person's actually been here for 3 years and the 3.6 person's been here for 2 years. Like, it would just be really interesting.
Chris?
And that kind of goes along with my question as far as, and how do you assure that when you're going not necessarily on time-based, but on competency-based, that the person isn't, so the person who's out of favor needs to have X, Y, Z rotation, but they're never going to be able to get put on that rotation because they're not the favorite of the program director. Because that has been something that I think they've done in Europe for a while, and that was, talking to my friends, you had to be able to you know, make sure you got on specific rotations to be able to get signed off on those rotations. And so if you happen to be in a program where it's very favoritism based, how do you guard against that?
Great question. No idea.
I guess that would be the idea, though, is to remove that type of favoritism by saying you just have to accomplish this task, so you just have to go on that regardless. You know, conceptually would be the idea.
But I think this also helps that it's more of a portfolio based than a single assessment based. Yes, Dr. Hersey.
So that's a great talk, and I think that there's a lot of people that get anxious about this. First, about the favoritism thing, I would say that's a benefit of being a broad program. So it's hard to have one person who just, you know, makes such a big effect. I think that there's a lot of trepidation of people to look at these changes in paradigms that make it seem like everything's going to change, it's going to be awful. I think this is something that we actually already do, but it's really important actually to put it, to codify it and be conscious. So the way we said it was, you start from the attending doing a case to being smart help to dumb help to no help.
Yep.
Right? And that's really the plan. And if you can talk about that with your trainee and say, today I'm smart help, or today I'm dumb help. I'm just going to stand here, you have to tell me what to do. I'm going to be a med student, or I'm going to be a junior resident. You have to move the retractors, you have to do the exposure. I'll stand here and I'll hold things, but I'm dumb help. It changes the attitude of the learner in terms of what they have to do. And I think it's really important to have a conscious discussion about that. And I think that very few of us actually do that. And in all truth, it actually would, I think, accelerate the learning process. And if anything, it puts it into a conscious level versus unconscious, kind of weird, unspoken thing between two professionals in a room, or one's trying to learn from someone, but you're not talking about what you're trying to learn.
And I think that's part of, as you're saying, the sort of categorization of things, because you know where people are and what they've done instead of it just being your own experience with them. And that really will help accelerate learning in a lot of ways.
Jen, I think that also speaks to not every, quote, attending physician is a natural teacher or has the skill set to take someone through these milestones that it takes. And it may not be that everyone's part of the evaluation process, that it may only be some that are part of it.
I would go a step further and say that the vast majority of surgeons are not great teachers, actually, myself included. I think that same sort of thing where we expect surgeons to be leaders and teachers, and we give them absolutely no training in this throughout their career until they're done with their training. You say, oh, by the way, you have to lead this group, you have to teach this stuff, and you've never been given formal training in it. And it's one of the only fields I can imagine that happens, where you're put in charge of, a multi-million-dollar business with zero business training, where you're put in charge of, 50 young professionals that are all, scoring higher than you did in your standardized test, and you're supposed to teach them, and you've been given no training to do so. It's insane, actually.
Are you signing up to do that, Dr. Hirose?
Well, I took a year-long teaching scholars program at UCSF. I know it doesn't tell. You can't, but the truth is, like, these concepts are really important. I think that we all should do that.
They are, and they're hard to wrap your head around a lot of times.
It's hard to internalize because you end up in actually the culture sort of drives what you do a lot
Yep.
of times. And the thing that you have to remember too is that there's a patient on the table. So then, like, you have to, it's hard to balance your teaching moments with the patient care. And I think that's really where it gets a little bit complicated.
I would agree.
How about Dr. Farkas for the last question?
Well, it's more of a comment, and just as, each one of us can't teach every technical surgical process. I mean, we're never going to show someone how to put an aortic graft in. I think also each probably attending has a different way, like some attendings are better at teaching, communicating with patients. Some are better being that technical teacher. So, I don't think, just as it's very hard to be the triple threat nowadays, I mean, there's some people who can do it, it's rare. It's going to be hard for one surgeon to be able to teach every facet of education. And that's when it comes upon the student to search out the specific teacher who's going to fit that different niche. Just like our mentors. We're not going to get one mentor who's going to be that guiding light. We're going to have many mentors who can mentor through us through our career in certain process.
Yes, and I think that's the goal of EPAs, and that's the goal of competency-based education, is that it is an overall committee, and instead of one person having to teach you everything. In an apprenticeship model, it's really very much a group effort to raise residents and make them into excellent surgeons.
All right, let's carry this forward, continue the conversation, and go out there and provide excellent care and education. Thank you.